From the Asgard Company Studios in beautiful Wichita Falls, Texas, from the finest mind in the modern fitness industry, the one true voice in the strength and conditioning profession, the most important podcast on the internet. Ladies and gentlemen, starting Strength Radio. Welcome to Starting Strength Radio. It's Friday, and as is true on every Friday, it is not Saturday, it's not Thursday, it's Friday. When it's Friday, it's Friday. And we're dead serious about that. I've always said Friday should be its own day, and here on Starting Strength Radio it is. And we're here this week with our buddy Jay Campbell. Jay is the author of this very important book, Testosterone Optimization Therapy Bible. And yeah, we've had a bunch of requests over a very long period of time to deal with testosterone replacement therapy, and we have been looking around for somebody knowledgeable to talk to. And we just asked ourselves one day last week, what is the best-selling book on this? And this is it. And therefore, we wanted to talk to the author of this book, Jay Campbell, and I've discussed some stuff with Jay, and this is going to be a very, very good show. You guys are going to get a whole bunch of stuff. I'm going to learn a bunch of stuff, and you're going to learn a bunch of stuff. And I appreciate Jay's time. This is a fairly controversial topic in some quarters, and in other quarters, it is so fucking obvious that this is what we need to do as older guys that it's just odd that anybody could feel the other way about it. Jay, why do you think the medical community is so resistant to the idea of testosterone replacement therapy?
Well, Mark, first off, it's an honor to be on your show here today, brother. I truly appreciate it. I'm humbled, privileged at the opportunity. So thank you for having me here. This is going to be an amazing show, and a lot of people are going to get clarification on what's really going on. But that's a great question to start the show off with, because truthfully, I could give you a bunch of different answers. You know, I could put my tinfoil hat on and tell you that, you know, over the last 30 years, testosterone levels have precipitously declined across the globe. And these are obviously numerous scientific studies that bear that out. But ultimately, and this is my personal opinion, the medical/clinical community does not understand this. Okay. It's not taught from a medical school level. There's no standard care of practice applied through clinicians across the country on how to do this. Most of the physicians that are successful in prescribing testosterone therapeutically have used it on themselves and have actually also been given the runaround, you know, with other physicians who started them and screwed them up. So we're in this weird world where there's only a few people, both men and women from a clinician standpoint, that actually understand how to optimize a patient's hormone levels.
Well, the interesting part the interesting thing and the most important aspect of the question about what is wrong with the medical community is that the vast majority of people who decide that they want to investigate testosterone replacement therapy are going to do it through a physician. And the first thing they're going to hear from their doctor is this big, long litany of bullshit that persists in this topic. So I guess a good place to start would be the list of bullshit. What is a guy who goes to his, God help him, his general practitioner and asks about testosterone replacement therapy, what's he going to hear from these people?
Well, the first thing, it's a great question. The first thing he's going to pushback he's going to hear is like, oh, you don't need that. You're fine.
Right.
Because the physician, again, knows very little about testosterone themselves. The average physician, general practitioner, PPO provider, has nothing as far as a clinical background and understanding the difference between total testosterone and free testosterone or estrogen or any of those things. And so henceforth, when that middle-aged man or middle-aged woman comes and asks about it, they just instantly push back because they're not technically qualified to have an intelligent conversation. Now, obviously, I'm talking about GPs and PPO guys, but an endocrinologist and a urologist may not say you're fine, but they also may say to them, "Oh, you don't need testosterone because," and then that because is a litany of reasons
I
that
have
they don't want to prescribe.
I have run into a lot of people who have heard this same litany of bullshit from their urologist. I've heard heard urologists say some really, really stupid things. The urologist is much more likely than it's been my experience. The urologist is much more likely to go ahead and do a test,
Right.
Do a hormone level examination, lab test on a person that asks them about that, and then they go through the numbers. They see the reference range. They see that their patient is somehow within the reference range, and because you're in the reference range, you're just fine. And this is so frustrating. 55-year-old guy goes to his urologist, says, I feel like shit. I'm kind of borderline depressed. I hadn't had blue steel in a number of years, and I'm interested in my brain, but my body doesn't cooperate. I'm sore. I'm tired. I don't sleep good.
Right.
Got no appetite. The whole list of things that indicate what is referred to as hypogonadism.
Right.
And the guy says, "Well, we can do a test. Go ahead. We'll do a blood test, and we'll see what. We'll send it to LabCorp and see what they say. And then it comes back, and they come back and they're at 312. Their total testosterone's at 312. And guy says, "Well, yeah, you're within the normal range. The reference range is 275 to 975 or whatever the hell they're saying it is this week, and you're within that range, so there's nothing I can do for you, And a guy says, "Well, after all, he is a doctor,
Right?
And so he walks out of the office, the same pile of shit that he walked into the office, and nothing has been done to help the guy because of this reference range thing. So I think a wonderful place to start this discussion is to talk about the reference range. What is a reference range? Just in general, in terms of blood tests, what's a reference range? What's the reference range for CPK? How was it determined? What's the reference, for example, what's the reference range for free testosterone, and how was that determined?
So basically, these are all great questions, and this is the story that you gave is exactly what happens to 95%, if not 99% of men across the country, and women for that case. But ultimately, we're talking about men. But basically, the standard range or the reference range for total testosterone and free testosterone was established, by the Endocrine Society. I don't know when it was. I think it was about 15 years ago. But as you said, it's moving every week. In fact, it's moved so far now that the high end of the range is 786 or 788. You can fact check me on that. And then the low end is 125. Now,
125
I've been on therapeutic testosterone
for a male.
Yeah, so it's insane. I've been on therapeutic testosterone for 20 years, right? And when I first started, the high end of the range, just to give you this variability, was 1360. And the low end was 400 plus.
Right.
So now they've compressed the ranges to obviously this, and again, they call it or refer to it as the standard mean deviation. But now we're at 780 and 130 or 124, whatever it is. And they will tell you that the reason they're compressing the range is because of obesity in America. But you and I both know that that's not true.
What does that have to do?
And the top clinicians, well, so they have an excuse, but the top clinicians will tell you that it's actually just them prescribing or further restricting the prescribing capacity of doctors. So they're basically eliminating the opportunity for men to get therapeutic testosterone. But they say that obesity obviously, which is insulin resistance, metabolic disorder, lowers testosterone naturally, which of course it does, right? But that's
Well,
not
of course
the
it
issue.
does.
The issue
And the
is
way
they're
we
just
get rid of those symptoms is to raise testosterone.
exactly.
Huh?
Hello.
What? Yeah,
It should be frontline therapy. Yeah, it should be frontline therapy for any man who walks into the office to get a bolus of testosterone in whatever delivery system. It will mediate, short-term memory. It eliminates depression, as you know.
Yes.
It increases energy. It increases dopamine signaling. I mean, it does so many amazing things, and that's why it should be frontline therapy. I even have physicians that say psychiatrists should be using testosterone for an aging man as frontline therapy over all the SSRI bullshit, brain adjuvants, because all those do is create dependency.
I've had that conversation so many times, Jay. It's I've had the conversation with psychiatrists. I've had it with psychiatric patients. A guy, and that is such an important thing that I think we'll go ahead and put this at the front of the show. My experience with this, my personal experience with it, and the experience of lots and lots of my buddies, has been that if you are a little depressed, like the kind of thing where you're driving home from work at night, and you find that you're crying for some bizarre reason that doesn't, you find that you have a female reaction to an emotional situation, this sort of thing, and you're getting tired of it, and it's bothering you. You're not sleeping good. You're worried all the time about this sort of thing, and you take a big bolus of testsipionate, 2 cc's, 400 milligrams of testsipionate in your left ass cheek, because you listened to me, and I decided that I would tell you this and share this with you, and you decided to go ahead and try it. And 72 hours later,
it's a miracle.
Your brain is back to normal. I can't tell you how many guys have walked in the gym after trying this and said, you were right. The last guy that did that I had do this to me, I saw him walk in the door, and I could tell by the way he walked in the door that things were better. This is not confirmation bias. I've seen this a lot, and I could tell that his brain was. You've seen what I'm talking about. It's just your attitude changes completely, and it doesn't. I don't know how you could convince a psychiatrist to try this, especially when there really isn't a downside to doing it. Because has anyone ever died from 400 milligrams of testosterone cypionate?
Not provably.
I mean, you can die from taking 40 aspirin.
Yeah.
But you can't die from 400 milligrams of testosterone cypionate. You could give your grandmother 400 milligrams of testosterone cypionate, and she wouldn't die.
No.
She'd be a whole lot more interesting for about 3 weeks, but she would not die.
You're right.
And it just astonishes me that since there's no downside, why don't you guys just try this as the frontline treatment for somebody that walks in the psychiatrist's office with mild depression? Why not? Why not?
Because they don't make money, Mark. They make money prescribing SSRIs. Testosterone's generic.
God damn, that's cynical, isn't it? But
it's the truth.
It's true. It's the truth. It is, in fact, the truth. So, in fact, it's been my experience that the most profound effects of testosterone replacement therapy are psychological, not physical.
Absolutely. Yes. 100%. No, you're actually right, because it increases cognition and it increases dopamine signaling pathways in the brain. And as soon as dopamine receptors are turned on, it's like, whoa, I got a new
I
lease on
feel
life.
better somehow.
Exactly.
Right.
Exactly.
So, if you guys don't take anything away from our little discussion today, if you're 55 and you just feel sad all the time for no apparent reason, I understand current circumstances here in 2020 make any intelligent person sad, but if you can divorce the sadness that you're experiencing from current events and you find that you're sad all the time, why don't you try this and just see what happens? Because the adverse effects of doing so are non-existent. They're non-existent.
That's true, by the way.
Physicians that tell you that testosterone replacement therapy is dangerous don't know what they're talking about.
Walk out of the office.
They have no idea what they're talking about.
No clue. Yeah, that's true. So, Mark, I talk about that all the time. When guys say that, I say there are no side effects. If this is done correctly and initiated from a physician, that understands what they're doing, there are no side effects. There may be a little bit of an adjustment dosage-wise, but there's no side effect.
Jay, even a physician who doesn't know what they're doing, that puts 2 cc's of testosterone in your ass, even if he doesn't even know how to administer the injection properly, there are no side effects. There just aren't any side effects. There's no reason to talk about a disclaimer here. There's no downside to this. I mean, I guess he could stick it in a vein. He sticks 2 cc's of oil in a vein because he doesn't know how to aspirate the needle correctly. Maybe that's a bad side effect, but that's not the testosterone's fault.
Mm-hmm. Well, we should say there are delivery systems that are bogus, right? Like the pellets.
Yeah, we're going to talk about all of that later because there's a lot of ways to waste money on TRT. Right. Whole bunch of ways to waste money on it, and the physicians that don't know what they're talking about are far more likely to waste your money than they are to kill you.
100%.
Right. So what's the rest of the bullshit? What do we hear about heart attacks? We hear about heart disease associated with elevated testosterone. Let's go through the list.
Yeah, so for sure. So the 2 biggest side effects, BS that you hear about prostate issues and then heart issues, right? Now, the reality of both is that, and again, this is all, substantiated with, literally hundreds of clinical studies from the last 10 years in the book, in the TOT Bible. And by the way, anyone who listens to this podcast with me and Mark can get a copy of the books for free, the TOT Bible. It's a PDF, of course. All you have to do is go to jccampbell.com/free books, and Mark can put that in the show notes.
Put that up. That's awfully generous of you.
Yeah, no, for sure, man. I give back. Yeah. I want men to understand what you and I are talking about because, like you said, it's so important. Good. But to your question, prostate. Let's talk about prostate before we'll get to heart. So most doctors think that testosterone therapy or TRT or TOT, I call it optimization therapy, can cause prostate issues. It's actually the inverse that is true. You only have a prostate issue if you have low testosterone because low testosterone causes benign prostatic hyperplasia. And then over time, it gets worse, which, obviously it elevates your PSA, which, by the way, the PSA is a worthless measure anyway.
Absolutely. We can talk about that as a separate issue. Oh, my God. There have been so many people unnecessarily operated on because this PSA bullshit.
Don't even get me going. Yep,
totally. God.
So anyway, optimized testosterone, you'll never have a prostate issue ever. And then going to the inverse again, heart disease or heart issues is also the inverse, that they now know that the majority of men who have a testosterone deficiency who have then suffered some form of heart, atherosclerotic or, vascular pathway issue had a low testosterone level. And that there was a study, it was called the TOM study, and it was in, I think, 2011. And they had a patient population cohort of men who were basically dying. They were all sick and pre-existing conditions. And a couple of them had a heart issue when they were given therapeutic testosterone. And may I add, the therapeutic testosterone that they gave them was androgel, which, as you know, is worthless. It's not therapeutic testosterone. So that was the study. Yeah, that was the
Standard
study
medical study. Jesus.
Yeah, that was the study they extrapolated to say that it caused these heart issues, which we now have know that is completely disproven. I mean, again, the opposite is true. If you are an older man and you do not seek testosterone therapy and you have a testosterone deficiency, you will have at some point a heart and a prostate issue. It's that simple.
The prostate's an interesting thing. That's the first thing the doctors want to talk about. Well, we give you, start taking a bunch of testosterone, you're going to end up with prostate cancer. All right. Who has prostate cancer? I'm not asking Jay, I'm asking you. Who has prostate cancer? Old men have prostate cancer. What is the testosterone level, typically, of an old man?
Low.
It's low. Why then would you associate high levels of testosterone with prostate issues when that's not what we see? Never. The phenomenology is that old men with low prostate show up with low testosterone, old men with low testosterone show up with prostate cancer. All right. It's this thing has persisted. This little nugget of bullshit has persisted in urology and in the GP's office for a long, long time, when it should be obvious that that's absolutely not the case.
Yeah, it's 60 years. In fact, the top GPs, or not GPs, but the top oncologists now, Mark, use testosterone with their patients that have stage 1 and stage 2 prostate cancer because they know the testosterone is a therapeutic adjuvant for someone that has a prostate issue.
It's protective.
But there's only a small percentage of those guys.
The story of PSA, you know, I tell you what, PSA is such an interesting topic that maybe you and I will get together on another show.
Perfect.
And talk about the history of the PSA exam, what PSA is chemically, what it actually is, what it does, why it's secreted, why it occurs, and what its physiologic, what that protein's physiologic purpose is in the body, and talk about this, because I had a good friend, mentor of mine, college professor, that is dead now, and it's a sore spot with me. It damn sure is, and you and I will get together and talk about that another time. Let's see. Cholesterol. It'll make your cholesterol go up. Why, it'll give you cholesterol.
Yeah, cholesterol. I mean, just a quick conversation about that. You already know, but cholesterol is a meaningless topic in and of itself. Genetic. Itself. Yeah.
Anyway. Despite its dubious association with elevated testosterone levels, it does not elevate cholesterol.
No.
And even if it did, who gives a shit? Okay? The bigger problem is statins.
Oh, yeah.
Yeah, we can do another show on that, too. That'd be fun. Statins.
Well, my God. Would lower your testosterone for sure.
Well, they do all kinds of bad things. All kinds of bad things. That's another hour-long discussion that we'll have at some point.
It's medicine, man. It's just insane what they do to people.
It really is. It really is. Insulin resistance. That's interesting, isn't it? Why would insulin resistance go up in the presence of a substance that increases muscle mass?
Yeah, exactly. It's the dead opposite.
It's like you're talking to Democrats, right? They accuse us of what they're guilty of. It's just exactly like that.
Show me proof, Mark.
Yeah. Now here's an interesting topic. This might actually apply to some guys of a particular age group, the lower age cohorts of people that actually might need to be on testosterone replacement therapy, might have their sperm count adversely affected by the administration of testosterone. Now, that has to be acknowledged. But
Correct.
how many 55-year-old guys do you know are trying to get the old lady knocked up at the age of 55? I guess it happens every once in a while, but this certainly doesn't apply to the population at large, does it?
No. Well, let's be honest, right? Like, just to address that, because guys will say, oh, well, I lose my fertility. Well, that's not true. You can use an ancillary medication like human menopausal gonadotropin or HCG, human chorionic gonadotropin, and that keeps FSH and luteinizing hormone high so that you do maintain motile sperm and you can still impregnate, your wife or girlfriend or whatever. Right. So it's like, it's not true that using testosterone will make you infertile. You just have to use testosterone intelligently.
Mm-hmm. But the fact remains that the vast majority of people who are symptomatic for hypogonadism are not. Those guys have long since given up on the idea.
Right.
They're going to get the old lady knocked up.
Correct.
Long time ago, I remember some discussions, and I think these were primarily the studies done on this were coming out of Europe, of using decadurabolin, which is an injectable anabolic steroid. It's not testosterone; it's a testosterone analog.
Right.
It's an anabolic steroid, an oil-based anabolic steroid for birth control in men.
Right.
And because it has the immediate effect of dropping your sperm count. And for a lot of guys, this is a beneficial side effect.
Right.
I mean, if a guy is young and active and shit, doesn't want to be in a paternity situation.
Right.
There are, a lot of people who would regard a lower sperm count as a benefit, as a beneficial effect of the therapy. So, but just to acknowledge the fact that does take place, in fact, testosterone replacement therapy can lower your sperm count.
Yep, for sure.
Yeah. But what are the beneficial effects? Let's go through that list, shall we?
Yeah, absolutely. So first off, you already said it, right? The first noticeable effect of a person that, optimizes their testosterone with a bolus of therapeutic testosterone is dopamine enhancement, right? Which is going to increase well-being. You're going to feel better. You're going to have that like lethargy or that sadness, as you discussed, go away. So you're going to feel better. You're going to have more energy. You're definitely going to have better cognition. Short-term and long-term memory is improved. And then, of course, energetically, you're going to feel like you have more energy, right? A lot of guys think it's sexual function enhancement. That's kind of like way down the list of all the things that it really does. Yeah, sure. If you have super, super deficient testosterone levels, a bolus is going to increase, sexual functioning. You're going to get better erections, whatnot. But most of the stuff is in the brain. It's going to be dendritic and synaptic pathway effects.
Certainly been my observation is that the primary initial effect, the 72 hours effect, is psychological.
Yeah, 100%.
It's a big, gigantic effect for guys that are tired of being depressed.
Sick and tired of being sick and tired.
Sick and tired of it.
Yep.
And here's how you actually know what testosterone does. Listen to the ads on the radio for Andro 400.
Right.
Listen to the ads for the oral testosterone boosters.
I think
and whatever they say that shit does, that's what testosterone actually does.
I think Bo Jackson and Frank Thomas do commercials for that. Yeah.
They do. Yeah, they do.
Yeah.
There's several of these things, and that's a big giant ass market right now.
Oh yeah.
it noticeably absent from any of their advertising, any of their claims, is the actual level of testosterone that got boosted.
Yeah, exactly.
All you'd have to say is my testosterone went from 127 to
150.
972, and I'd buy some of the shit. Right? But they never say that because that's not what happens.
It's so funny though, because we have a whole chapter in the book on investigating the science behind all the over-the-counter supplements, and they're, as you know, abject fraud.
What do you think they actually do? What's in that shit?
Well, some of them, I can name a couple, but I won't. But some of them will increase, what's the word I'm looking for? Libido. It'll enhance libido.
Well, that's
but nothing is going to increase free testosterone or total testosterone from anything beyond a transient level.
Those things are primarily horny goat weed.
Yeah.
And other vasodilator type chemicals, the same basic stuff that's in Cialis.
Exactly.
And one of the interesting side effects of Cialis, and because it's got such a long half-life in the body, and to a lesser extent Viagra, is the fact that not only does it dilate the vasculature in the erectile mechanism in the penis,
right,
it also dilates your lower esophageal sphincter.
Yep, that's absolutely true.
And causes GERD, gastroesophageal reflux disease, or the symptoms thereof.
That's correct.
And those of you guys that are taking Cialis, taking Viagra, and notice you've got heartburn, that's why. It's a trade-off, It's a trade-off. And depending on your particular situation, it may not be worth it. But be aware of the fact that it does that. And the herbal stuff does the same thing, too.
To your point, Mark, guys should use a very surgical dose of Cialis so that they can minimize that. But like you said, some guys are going to need a bigger dose to actually get the effect. But if you can use a very low dose of Cialis, you can minimize those effects. But you're right. Some guys, they need a bigger dose. They just have much more issues. Their endothelial function is very, very off.
Yeah, and that, a lot of that has to do with the rest of their health picture.
Exactly.
Are they training? Exactly. How what's their diet look like? All that other shit. Do they have accompanying type 2? How much metabolic syndrome symptoms do they have? All of that will blunt the effect of those drugs and cause you to need to have more of them. What about all the other stuff that are claimed for the testosterone boosters? Body fat, stomach fat, muscle mass, all that stuff.
So testosterone, as you already said, is lipolytic in nature, so that it increases basal metabolic rate. It uncouples from a thermogenesis standpoint. So basically, when you use testosterone, you are going to have an accelerated body fat, loss, because it's lipolytic. It increases all those things. But ultimately too, it increases, muscle protein kinase turnover and gives a person a positive nitrogen, anabolic response signaling. So a person that's training, obviously with weights, which I hope you are when you're using testosterone, is going to be, pro-nitrogenic from a standpoint of they'll be able to put on muscle easier. Now, a therapeutic dose versus a super physiologic dose, and obviously we're talking about therapeutic doses here, is going to still allow a person to put on muscle mass a lot easier. Now, something else that testosterone does, which is huge, is for aging men, is improves bone mineral density, right? So as a guy gets older, the skeleton becomes more compromised if you're not supplementing with therapeutic testosterone in combination with doing, bone resistance training or whatever you do from a resistance training standpoint. So, again, you already said it does so many things from a positive standpoint to help an aging man that it's almost insane not to consider using therapeutic testosterone once you get to an age where your levels are just not optimal. Not normal, optimal.
Right.
Big difference.
Optimal is normal is once again a
BS.
An interesting concept that's based on this wholesale swallowing of the reference range idea.
Right.
So it's obvious at this point that, and you'd mentioned this earlier, that testosterone levels have dropped over the past decades. What's the what do you think? And these are significant drops, 50, 60% in some studies, from averages up in the 900s to averages down in the 400s. What would be responsible for something like that?
I mean, the answers are, again, pretty explicit in the book, but the clinical community will tell you that it's just modern day living. That essentially human endocrine systems are under assault now from the chemicals, from the air that we breathe, the food that we eat, the toxins that we take in, the blue light from the technology and our devices that are all over us, because that also reduces endocrine system response and biological system response. But ultimately too, I mean, people just do not take care of themselves. People are over consuming fast food, drinking too much alcohol, eating too much sugar,
Sure.
not exercising, right? Like how many people are sedentary?
Well,
So
I don't know much about the blue light or any of these other rather esoteric explanations for this, but I do understand that obesity is way up. Diet has become much more carbohydrate dependent because of the
simple food.
Our friend Ansel Keys many years ago blaming carbohydrate ingestion or fat ingestion for heart disease. And of course, if we have to stop eating fat, we need to start eating Snackwell's cookies. And the effect the effect of that on type 2 diabetes would be hard to overstate. As levels of type 2 diabetes go up and levels of obesity go up, concomitantly we see muscle mass levels going down. A complete radical shift in body composition across the world. We have far fewer men doing manual labor jobs, especially in this country. Farming is now machine-based instead of labor-based. These changes across society more than adequately explain the change in most men's physical existence.
Yeah.
Our physical existences are different now than they were 60 years ago. And
Dr. Anthony Jay wrote a really good book too that I think we could probably bring up real quick. It's called Estrogeneration, and he's like the Mayo Clinic's lead researcher on the anthropomorphical changes that are happening right now in like body composition between males and females. And he basically says that again, it's just phytoestrogens are everywhere. They're in the food, the air, obviously they're in the plastic and the water bottles, the PCB, the phthalates, all of that stuff contributes to, second and third generational changes at the gene level. And that's why men are less masculine and women are becoming more masculine. You take tests of 17, 18-year-old girls, 17, 18-year-old boys, and you see it. It's incredible.
I kind of like masculine women. Does that make me bad?
No, I feel you, brother. My wife is a beautiful woman, but she's got a masculine side to her.
Well, I don't think there's anything wrong with that, but I think that as a culture, we have over the past 20 years, the pussification of popular culture with respect to male behavior is
nuts.
It's a shameful situation. We remember the iconic pajama boy from the Obama administration's Christmas advertising that year.
The soy boys.
Yeah, these people are not all of them accept that, and a lot of them are trying to undo this effect, and that's been good for our business here. But the more popular culture tells men that it's okay to cry, the more problems
Yeah.
men are going to have as a result of that, because, men are not supposed to cry easily.
Yeah.
Now that's going to, I don't think that a lot of people that watch this show would have a problem with that statement. And if
But
you
it's
do have
true.
a problem with that statement, you're probably crying right now because you're so upset that I would say that. Look, boys, men are not supposed to cry all the time. When your dog dies, that's fine. Okay?
Right. Yeah,
when your
exactly.
dog dies, you get to cry. When your mom dies, you get to cry. But when somebody tells you no, you don't get to cry. This is not the way your psychophysiology is supposed to function. And I think it's very important to think about that, because throughout history, men are not known for crying just at random on the way home from work at night. That's not what we do. We're not supposed to do that. And if you are doing that, perhaps you have had your standards lowered.
Yep.
Or perhaps your testosterone is low.
Yep. It's about the best way you could say it. Dr. J in that book, Estrogeneration, did say too that, and again, there's proof of this now, that using birth control, women started using birth control 30 years ago. That washed off into the water supply. And now they see fish and all the freshwater streams becoming feminine. So
I've heard that mentioned.
Yeah.
Those compounds are rather stable.
Yeah.
And they do end up in the water supply. That's certainly true. You mentioned Alzheimer's in here.
Yeah.
That's an interesting topic. How do you think testosterone plays into the Alzheimer's disease question?
Well, that's a great question. There's differing opinions, but if you ask Dr. Mark Gordon, who's probably one of the world's foremost traumatic brain injury doctors, working with a lot of ex-military and law enforcement folks that have suffered TBIs, he says that he can prove that testosterone, or deficiency of testosterone, leads to amyloid plaque formation. And obviously, with for what we know of right now with Alzheimer's, if you have amyloid plaque formation, which is really type 3 diabetes, by the way, because that's a whole other conversation.
I've heard it called that for years. Yes.
Yeah. So essentially, if you have that, you're going to get down that pathway. So as you and I, Mark, have already discussed on this show, testosterone mediates type 2 diabetes, adult onset, right? It's improving body fat loss, improving insulin sensitivity, increasing metabolic rate. So why would you not use therapeutic testosterone to also mediate / mitigate any kind of neurodegenerative disorder, whether that's Alzheimer's or dementia?
Have you seen any indication that women with Alzheimer's could beneficially respond to testosterone therapy?
Oh, 100%. I mean, there's a couple studies in the book that lead down this pathway talking about that. But there's no question. I mean, again, male and female physiology are essentially the same. The only differentiation is that men have more levels of testosterone. And as you know, give a woman super physiologic levels of testosterone and she turns into a man. So, it's
she
pretty
tries
simple.
to. She doesn't quite get there, but she tries to.
Almost.
All right, now that we've kind of established, at least in our minds, hopefully yours, that testosterone replacement therapy is a good thing for lots and lots of people. What is the best way to do this, Jay? What do you, if you go into the GP's office, you go to your urologist, they're going to want you to use a patch or a cream or something like this. And for some bizarre reason, none of them will just put a shot in your ass. I don't understand how they think they can deliver a precise dose of testosterone transdermally. It's as though they don't care about the level when they do it like this. What the hell is going on here?
Okay, so again, great question. there's two delivery systems. There's really one, but there's one new delivery system that actually does work transdermally, and I'll explain it in a second. But the tried and true method of testosterone replacement therapy is obviously an injection, right?
Yes.
Now, what we've learned in the last 10 years, really tweaking this, is understanding that what you want to do as a physician, and then of course a patient following along, is you want to mimic the body's natural release, okay? The endogenous release and pulsatile diurnal release of testosterone through the body. So the best way you can mimic that with an exogenous, external source of testosterone is by injection frequency. So the best way to really do this today and really get as close as you can to the body's release of testosterone is to inject. Some guys, honestly, right now, Mark, inject every day. They use like a little HCG needle, an insulin needle or whatever, and they just have a small little bolus every single morning and do that. But I found,
and that's a sub-Q.
Sub-Q, exactly.
And sub-Q is a delivery bolus is just fine.
Yep, exactly. And then, but I find from an IM standpoint, so again, shallow muscle, 3 times a week. So it's like basically every other day and taking the weekend off, right? Now, some guys can inject twice a week, and that's fine. And a lot of guys don't want to inject themselves 3 days a week, right? But again, if you want to mimic the body's natural pulsatile release, the injection frequency matters. And then the second format, and everything else is useless, is transdermally at the base of the scrotum. Now, the reason you can do it at the base of the scrotum is because the scrotum, the epididymis, that skin level right there at the base of the scrotum, it's so thin and so permeable that you get, and there's 3 studies on this right now out there, but you get 8 times the best absorption or efficacy of a transdermal release right there than you would anywhere else on the body. So I would agree with you. If you put it on your arms or your forearms or your inner thighs, you're not going to get the absorption that you get on the base of the scrotum. So there's 3 doctors right now in the world that have really pioneered this and have really patented this. In fact, I switched after 18 years of injections to doing it that way. And honestly, it's the same. You get the same effects as you get injectable. The only difference that I feel, and again, it's my opinion, right, but I've been doing it now for 2 years, is you do get a little bit enhanced sexual functioning because when you put the cream at the base of the scrotum, well, you get dihydrotestosterone. So you're going to get a stronger DHT signal right there. And so that obviously is the primary anabolic hormone, even more so than test. And so you will feel a little bit better sexual functioning, especially in guys in monogamous relationships. But beyond that, it's the same. So injections, cream on the bottom of your nuts, everything else is BS. Everything.
Right. The patch on the shoulder ornament.
Garbage. Totally worthless.
It's and it gets on your wife, and she may not like that.
Yeah, it's worthless, dude.
And
it is important too, Mark, to know that it's got to be 200 milligrams per milliliter of the cream. If you're using anything less than that, like an androgel dosage, like 10 milligrams or 30 milligrams, that shit's worthless. It's got to be 200 milligrams per milliliter because, again, the cream has a different half-life. It's much faster than an injection.
Right. Now, what about varying the ester with frequent injections? I remember a long time ago, testosterone propionate was available as a much shorter half-life ester than either testosterone cypionate or testosterone enanthate. Enanthate is what's generally available in Europe.
Correct.
That's the long half-life ester over there, and we use enanthate in the United States. But propionate was available a long time ago. I haven't seen it available in a long time. What's the thinking on propionate now?
It's a great question. In my first book that I wrote in 2015, the TRT Manual, which is like dead now, but still a very high-selling book, we liked propionate due to the exact reasons that you spoke. It is a shorter half-life. The inter-individuality of testosterone release is more noticeable with a shorter half-life agent or ester like propionate. But fast forward 6 years now, and we've looked at testosterone, under the microscope, and we've looked at how it cleaves molecularly. And at the end of the day, testosterone is testosterone, right? So if the propionate half-life, which is somewhere between 36 and 42 hours, estimated, and the cypionate is between say 56 and 72, Again, if you're doing frequent injections, it's not going to matter, right?
Right.
What matters is that you get a stable injectable solution that's not full of cottonseed oil and other bullshit impurities that the pharmaceutical companies, put in there. You need to get a stable carrier molecule like grapeseed oil or medium chain triglyceride oil or something that's not going to cause a histological response in the body. And as you know, a lot of guys inject the garbage pharmaceutical products and literally get infections or get some sort of a reaction, and they get, puffy skin, cellulitis. So that's the most important thing now.
Some of that reaction is a result of the benzyl alcohol
Exactly.
and
Yep.
benzoic acid that are used as sterilizers and stabilizers. And some people are real sensitive to that. But you think that there is a downside to the use of cottonseed oil as a suspension agent for the ester?
Oh, absolutely.
Really?
It's full of GMO products. Yeah. No. And I mean, they've seen now, like with the guys out there that that prescribe the compounded pharmacy blends, they see, with their patients, there's a much less issue with than just the cottonseed oil. Because again, the cottonseed oil is the old school, pharmacologic, big pharma usage. That's what they use as the carrier molecule. But there's just so many agents or additives in that. It's just not as good as like a thinner oil that's more absorbable.
I remember that Upjohn decades ago used sesame oil.
Yeah.
As their suspension agent.
Yep. And sesame oil is a lot better than cottonseed oil. But if you look at big pharma and you look at, the main, generic providers of cypionate, that's going to be the main carrier molecule. Now, if you see the underground community, right, they're all using either MCT oil or grapeseed oil for the most part, or what you just said, what was it, sesame oil. So they're using those three, then whatever the solvent is, which will be like propylene glycol or oleic acid or whatever. But most men today, if they're inflamed and they inject cottonseed oil, they're going to have a reaction to it. I shouldn't say most, but a sizable number of men will.
I've never had a reaction to an injection like that before, so I guess I'm probably okay. But you would say that if you've got injection site irritation, then then probably it's the carrier oil that is the problem, right?
Most of the time, yeah, 100%. And
if you're using sterile technique and you haven't screwed something up.
Well, some guys, it's a good point though, because some guys, as you know, also will respond to if they're using propionate, because there's that agent is more water-based, aqua, whatever the solvent they use in it, that can burn too. So some guys are a little sensitive to that too. But it's out there. Propionate's still prescribed. There's actually docs now that there's compounding pharmacies that use a combination of propionate and cypionate together. But to your question originally, because I didn't answer it, I don't think that there is that big of a difference if you use a short-acting ester with a longer-acting ester, which, as you know, in Europe with Sustanon, that's what they do.
Is that what Sustanon is? I've heard of that, but I don't know what it is.
Yeah, so Sustanon is like 4 different esters. But again, at the end of the day, once it cleaves, it's still
testosterone.
Yeah.
So let's talk about some of the other delivery mechanisms that you might be presented with if you go in for TRT. How many men are offered an implant, a pellet? I know that women are treated with a pellet, a sub-Q pellet, real frequently. And that pellet is typically, depending on the age of the female, it's a combination of estrogen and testosterone, and for older women, or for younger women, it's just testosterone.
Right.
And I have never heard of a male being offered a testosterone-only pellet. I'd be very skeptical of that myself because of the absolute defeat of the pulsatile mechanism of that would have on the levels of testosterone. But testosterone levels go up and down in a normal male.
Right.
And if you've got a pellet that goes in and erodes slowly over 3 months.
Right.
I've never even heard of that. Is that actually going on in certain
Mark,
clinics?
it is so incredible. It is the biggest replacement business going. It's a
I didn't
billion
know
dollar
that.
a year. And let me just say this right now. Obviously, I'm very anti that. It is proven unstable. Let's get the big picture of why it's garbage, right? As you just said, every person is biochemically unique, right? So you implant, basically a pellet of testosterone. And by the way, just so you know, there's actually guys out there implanting pellets of testosterone and an AI together, which is absolutely a fiasco. But everyone's going to cleave that testosterone individually differently, again, due to biochemical, uniqueness. So
Right.
some guys are going to cleave all that testosterone in 6 weeks and then be left to sit there and die for the next 6 weeks until they get to the next pellet insertion. Now, the other issue, which is the biggest issue,
Now-
is that you're having a non-surgical doctor cut you open, right?
Perform surgery, essentially, because it is invasive.
It's absolutely
It's
invasive.
far more invasive than a simple injection.
It's absolutely invasive. I have a folder on my desktop, which I can't show you, obviously, for private purposes, but people send me emails all the time and they show me their extrusions where they had a surgical implant, and it's the most horrific, god awful, they're infected. They've got, oh, dude, it's the worst thing you could ever possibly do. It doesn't make any sense. And Mark, by the way, it's literally between 8 and 10 times more expensive than injection or cream.
Wow.
That's how expensive it is.
That's
It's
amazing.
insane.
Well, I
But they
notice,
sell
my experience with it has been they're offering it to girls.
No, they offer it to men.
But the boys, I've never heard of anybody getting a testosterone pellet. That seems kind of stupid to me.
Well, guess why they sell it? Just so you know, guess why they sell it? Because men
they
are
make a
pussies.
hell of a bunch of money.
Men are afraid to inject themselves.
The pellet is $325 if you have it done around here. For
Right.
the women are paying $325 for a 3-month, quote unquote, 3-month pellet. The pellet is probably worth about $15.
Yeah.
And
Less.
so it's a high markup item, and I know why they're using it. But yeah, I do see a lot of reluctance among men to give themselves a shot. Poor little guys. Poor little things. They just can't bring themselves to. Hey, give us a shot. That might hurt. God.
Dude, needlephobia is huge, man.
Oh,
Huge.
Jesus Christ! All right, well, let's pick up on something you mentioned earlier. AI is an aromatase inhibitor. Let's talk about aromatase inhibitors and what they do.
So, man, this is a whole nother podcast, but I love talking about this. And quite honestly, I learned a lot about this in the last 4 years because when I first started writing about testosterone, I was under the impression that, an AI in a precise surgical dose was okay. But the reality is very simply this. You never, ever, ever, under the very most extreme circumstances for a guy that has, or a woman that has, some sort of genetic defect, you never want to prescribe an aromatase inhibitor because estrogen is actually, at the end of the day, as important, if not more important, than testosterone. Because
this is exactly what I wanted to talk about.
So listen, so estrogen confers all the biological effects that a male and a female needs to grow. Bone mineral density, brain synaptic pathway issues, vascular issues. Estrogen is what prevents all the issues that you would have in your heart, right? And there's so many other things like fluid viscosity in the joints and the soft tissues. So there's so many things that estrogen as a pleiotropic hormone must be allowed to do that inhibiting its formation, and obviously it's through the aromatization of testosterone, you are suppressing every biological system
let's not assume that's obvious, all right? When
Right.
you aromatization is the chemical process by which the precursor hormones are converted into the downstream versions.
Right.
Would you?
Exactly.
So we start with pregnenolone, right?
Correct.
Can we talk about the cascade there?
Very good, Mark. Very good. You want me to talk about that?
Yeah, I do.
Okay. So essentially just big picture, because I don't want to go too in the weeds for people, although I know you have a lot of smart guys on your show. When testosterone comes into the body, whether it's injected or through a cream, obviously it does aromatase into estrogen. And estrogen, there's a bunch of different, you've got there's three different hormones of estrogen. Again, I don't want to get into the weeds, but it's critically important that estrogen is allowed to not be blocked. Because again, estrogen confers all of the biological benefits: heart protection, joint protection, bone mineral density protection, brain protection. I mean, so many things that, again, as you said, estrogen is doing downstream.
And aromatization is the process by which one of the end groups is cleaved from the basic hormone molecule, right?
Right. Exactly.
The steroid molecule. Right?
Exactly.
And now AIs, aromatase inhibitors, have a therapeutic purpose in breast cancer, right?
And that's it. And even it's debatable.
Right.
Right. 100%. But
so a cancer that is susceptible to the presence of estrogen in a breast cancer or an ovarian cancer would benefit from the blocking of that at the receptor site with an aromatase inhibitor. In other words, if we can keep estrogen from being produced from base hormones, then we can prevent the susceptible neoplastic tissue from reacting to the presence of estrogen and therefore manage those cancers more effectively, right?
Very awesome. You just said neoplastic.
Yeah,
you got this, brother.
I'm bright.
You know this.
I'm bright.
But no, it's true. But just to that point too, that's also theoretic, right? Because if you talk to the smartest oncologists today, they will also tell you that even a woman that has breast cancer or some form of metastatic tumor, isolating, with a medicine such as an AI is theoretical too, because there's no way to know that it's going to be specific to that tissue or to that receptor. Mm-hmm. So again, it's kind of like a shotgun approach. But anyway, let's go back to AIs and why they're in male.
Right. In our discussion today, what's the problem with them? And why would somebody decide to use that? And what's wrong with it?
So it's just real big picture. And by the way, I'll give this guy credit. There's a physician. He's actually an ex-pro bodybuilder. I think he got his pro bodybuilder card, but his name is Dr. Scott Howell, and he's in Chattanooga, Tennessee, and he helps pro bodybuilders now come off of super physiologic levels of testosterone, and then also obviously AIs. Right now, here's the thing, and I just want to glance over this, and then we'll get into the conversation. We now know through Scott's work and researcher, and by the way, he's an epidemiologist, and he now knows that the issues that pro bodybuilders have, guys that are on massive amounts of gear and everything else, the issues that they're dying from are actually caused to the aromatase inhibitor, because what the aromatase inhibitor does, obviously in blocking estrogen, blocking aromatization and the pathways, it causes micro seizures, okay, in the plaque and in the vascular networks, which lead to heart attacks, MIs.
Really, the absence of the estrogen affects the plaque structure itself?
Exactly.
Really?
Exactly.
Does he have an explanation for that?
Yeah. I'll connect you with him, and I have a podcast and a couple blogs, but he's the smartest guy on the planet with that. He just talked to Dave Palumbo about that, but it's very, very late stuff. But anyway, that's also in the book, and he's a good friend of mine. But at the end of the day, somewhere along the line, about 15 years ago, and I may be going back a little bit further than that, the bodybuilding / strongman / performance community saw or thought, and it obviously extended into the clinical world, that if you had high levels of testosterone, you needed low levels of estrogen. Mm-hmm. Okay, that's what they thought. That's what they saw. And I think most people, including yourself, including me, who were trained in this, somewhat formally, somewhat, in the gym, had that same, approach. And so then
it seems superficially logical.
Right.
Right. That if you're trying to carry high testosterone levels, you don't want estrogen in there competing
right
for the receptor sites. But that's probably not what's going on, is it?
Exactly. Right, right. Well, what's going on and now, and again, credit to Scott on this, and he's taught me a lot, is that regardless of the level of testosterone that you use, whether it's you and me talking about therapeutic or it's a super physiologic bodybuilder or strongman, you must allow the testosterone to cleave through aromatization to its basic level based on your biochemical individuality.
Right. Because it's going to happen anyway.
Exactly. So blocking it is the dumbest possible thing that you can do because, again, you are literally stopping the pleiotropic effects of estrogen, which, again, is what confers all of the positive beneficial effects to a human biological system. Right. It's insane that people continue to do it, and doctors are out there, as I said, putting it in solutions, Mark. Imagine getting a testosterone bolus that has an AI in the oil.
Right.
That's what's going on out there.
Right. It seems rather dumb, but well, if the benefits of estrogen, I guess we're talking about estradiol as the ester, are obvious. Do we supplement estradiol?
Nobody's ever asked me that question. I got to give you a golf clap. Yes. For men that have genetically low levels of estrogen, which many do, and then they take therapeutic testosterone and their number still only goes up just a slight, smidgen, it's actually usually a really good effect. In fact, the top docs out there right now between oncologists and what I call optimization doctors, for men that have stage 1 prostate cancer, they're giving them estradiol. They're giving them 2.5 to 5 milligrams of estradiol because, again, that is going to increase the aromatization that they genetically are not getting.
So if you don't aromatize enough testosterone to estradiol, it would be beneficial to take some estradiol too.
100%. Dr. Neil Rougier, who's one of the top physicians / clinicians in the world that, is talking about this, who I've been blessed to do a couple podcasts with, that's what he does in his patients. I mean, he gives them estradiol. Again, it's like tantamount. People are like, what? But again, as you know, medicine is always learning and always evolving. But yeah, well, absolutely.
It's not all doctors are, though.
No.
Yeah, it's interesting that the aromatization of testosterone to estrogen compounds is pretty well understood, and it's a natural side effect of finding the correct dose of testosterone for the guy.
Exactly.
Right? That's part of the calculation. And I find it interesting that aromatase inhibitors are so popular. It's just, you cannot, and one of the most important things that you understand when you start looking at this in depth is that you cannot manipulate any level on the hormone axis, without impacting the other levels else too.
Correct. It's a downstream thing. Yep, yes. Absolutely.
But the important thing to remember is that if you stick a hormone in, all right, the tropic hormone above that is going to be depressed because you've already got a level of the hormone it is trying to cause to be secreted. Right. Underneath it. And all of those things are perturbed when you add a hormone. So you had better tread carefully. And when you start throwing in aromatase inhibitors and stuff, you're affecting things that you don't even know occur. And part of the, as I just mentioned, part of the way you titrate up to the correct physiologic dose for testosterone optimization therapy is to find out how much you need to achieve all of these effects, taking the aromatase process into consideration. You're going to get some estradiol out of the end of this thing, and it's supposed to be there.
Well said.
And so how then do we correctly titrate the dose of testosterone replacement?
It's a great question. And, one of my mentors taught me that the twofold goal of testosterone optimization therapy is happiness and balance, right? So you are going to figure out how you feel good and you feel balanced, right? Because some guys on a dosage that's too high are going to be a little bit irritable or have a little bit of mood instability. And until you get to that level, and again, your dosage is probably going to be, some guys they figured out in 3 weeks, some guys they figured out in 6 weeks. But ultimately, when you feel really good and smooth and cool as a cucumber, you're probably at the right dosage. Now, I tell guys, and again, there's obviously a lot of variability now, but I think that most guys do pretty good somewhere between 175 and 250 milligrams a week. And again, the more frequent the dosage, the more frequent or the better they're going to feel. Biologically, they're going to mimic the endogenous release of testosterone. Right. Some guys need more. There's no question. The best doctors know that it's not about measuring the levels and the standard mean deviation. It's again about how they feel.
It's the subjective effects because of the fact that the reference range is bullshit.
Total bullshit.
The guys I've talked to about this will all tell you that the reference range is meaningless. If you are having symptoms, then we treat, and we titrate up to symptomatic relief. And whatever that is, and whatever reference range, whatever level that generates in the patient is the level at which we're optimum.
That's 100%. And let me just add to that. There's a caveat to that, because I would have always said that that's the exact right answer. But the caveat now is that the system, the medical system itself, is starting to audit patient files, right? And so if you see a guy that has a 2,600 level total testosterone, that guy might feel amazing, Mark. He might be exactly what you say. He has zero symptoms. He feels amazing. His life has changed. His sex drive is great. He's got blue steel. But if that state medical licensing board audits that physician and they see that number, that physician is going to be called out on the carpet and you're going to say, what the hell is this? And then that doc is going to be like presenting your case. Hey man, this is normal. So it's important that we put that out there that, you got to work with a doctor that understands that, because some doctors will see you at 1,200 or 1,500 and say, oh, I got to lower your dose.
Right. They're afraid of their oversight.
Exactly.
In a situation like that.
It's not their fault either. They're doing their job.
And I understand that. But I want to pick up on something you said just a second ago. That relates to the first topic we talked about today in the show. You said happiness. When we're talking about depression, and I want to ask you about this because I presented this question to a couple of psychiatrists I've had this conversation with, and I want to see what you think about this. As a general philosophical question, what is the opposite of depression? All right. Now,
feeling good.
Stick with me here. Is it feeling good? Is it happiness? Is it joy? Or is it aggression? Now, by aggression, I don't mean wanting to be in a fight. That's not what I'm talking about.
Right.
What I'm talking about is the fact that when a person is depressed, what do they typically do? They sit there with their hands in their lap and they stare at their hands, and they don't do anything. They don't do a goddamn thing.
Right.
It's like waking sleep.
Right.
Versus a person who is normal and in command of their situation. How do they feel?
Right.
Happiness is a downstream effect of, and I hesitate to use the term aggression, but I don't know of another word for it.
I'll give you one. Strategically assertive.
Okay. All right. That's assertiveness would be a good synonym for what I'm talking about. A person who is depressed is not assertive at all.
No.
A person who is depressed is not is minimally responsive to external stimuli. They just receive things. They don't react to them. And I think that if you look at the depression aggression axis in this way, that the role of testosterone becomes rather obvious. Mm-hmm. And I think that's an excellent way to think about it. And I've mentioned this to a couple of psychiatrists, and they say, well, that's interesting. That's interesting. I'll have to think about that.
Mark, if there was only testosterone in a pill.
Yeah. Yeah, it'd be better, wouldn't it? Would be better. I remember methyl testosterone used to be available in a pill. Is that still a thing?
Well, so let's talk about that. So about 3 months ago, a company called, I think they're Clarite Therapeutics. They have their own capsule now, and it's obviously just the old school andriol, and it's called Jatenzo. So it's basically, testosterone in a very low level in a capsule with an oil based that you can take. But again, if you're familiar with
it has to be in an ester form, or it won't get through the stomach.
Well, the reality of it is it's in a very, 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 very poorly solvent ester, and so again, there's no hepatotoxicity because it's not methyl alkylated, right. But you have to take a bunch of these during a day. So again, it's another example of like the pharmaceutical industry getting a man to bump up a little bit in the normal range, right? Mm-hmm. But also cost a lot of money. And so
it's nothing I would be interested in doing, since injectable testosterone is quite inexpensive.
Yeah, exactly.
If you could get somebody to write you a prescription for it. So
right. Well, what do you call it? An insurance payment scam now too, because they'll start offering that to men, for $1,000 a month. Yeah, it's crazy, dude. God. And they won't even feel testosterone. It'll just be a slight bump.
Right. Well, so having said all of this, and now we've got kind of a theoretical background for what we want to try to do. Who are we going to get to do it for us? This is the biggest problem that most guys have got. They don't have access to somebody who has his head out of his ass,
right,
to help him with this.
Yep.
This is a giant problem. TRT clinics solve some of it. Those things have sprung up, and where you can go to your urologist, and he's going to first tell you that you're normal at 271, and that second, he'll let you try some cream, if you'll promise not to, tell anybody you're doing it or whatever. And then third, he's going to say, well, your level's back up to 475, so I'm not going to write you any more of the cream. All right.
You're fine.
So you're fine now, like you're going to stay that way. So that's what most people run into. So the way they fix that is they go to the TRT clinic. And the TRT clinic will test you because that's just part of the formal thing they have to do. And then they're going to give you an injection. And you go in every week and you get the injection. But your thinking on this is that once a week injection is not optimum, and that every other day, Monday, Wednesday, Friday, is a good injection schedule. But in order for that to be the case, the guy's going to have to write you a prescription and send you home with the vial and the needles, and trust you to do this the way he's telling you to do it. If you can find somebody that will do that for you, and usually you can't. So we have the idea, we know what we need to do.
Yep.
But how do we get it done?
So it's a great question, maybe the best question on the show. And I've told you this like off air. There's maybe 10 amazing hormone doctors in the world.
Right.
And I happen to know
I don't know any of them.
Well, I know the best one. So, like, are you comfortable with me recommending a couple people right now?
If you think they don't mind,
Oh
and
no, they don't mind. No,
and if they
absolutely,
will work with people in a remote setting, yeah, sure.
absolutely, yeah. Well, let's talk about that. So, since COVID, whatever that is, don't say anything, Mark.
Okay, Jay, I won't. Well, it's over now. I didn't want. Oh yeah, yeah. That's all. That's all gone now. Right.
So since COVID or whatever it is, they do now have they've laxed telemedicine laws. So now anybody anywhere can work with a doctor remotely through Skype, through Zoom,
Really?
through whatever.
Well, let's have us some more of that COVID shit then.
There you go. There you
That's
go.
going to
There's some
save a bunch of
benefits
people
to
a bunch of money and time, isn't it?
it. So let me give you three doctors in the United States. They're amazing. There's one guy who's in Chattanooga, Tennessee, and his name is Dr. Keith Nichols, and I'll give his link out. It's tier one, TIER1, the number, HW, healthandwellness.com. So tier one, HW.com. That's the guy, Dr. Keith Nichols, and then his partner is Dr. Scott Howell, and he's the ex-pro bodybuilder that now helps guys come off of super physiologic levels. Both of those guys are the best. They know more about this.
Well,
Keith was like the doctor for the Nashville Predators, and then also the Tennessee Titans, and then he was also involved in MMA. You know, he knows Dana White and all those guys, so he is brilliant when it comes to this. And then, of course, Scott is the smartest guy on the planet with understanding the epidemiologist effects of estrogen. Another guy is Dr. Rob Komenarek, and he's in Dayton, Ohio. And his website is Renue, RENUE health.com. Also, very close personal friend of mine. Amazing. Been prescribing hormones for 24 and a half years. And then the other guy is Dr. Jim Meehan, and he is in Tulsa, Oklahoma, and also very advanced former ophthalmologist. I mean, still an ophthalmologist, but, you know, he has his formal training, and then he was quacked, and he went down this path. And he learned everything, and now he's like one of the guys that lectures and talks. Now, there's a lot of other guys named, you know, with big names in the industry. You know, I could say Dr. Mark Gordon, brilliant, but Dr. Mark Gordon doesn't take new patients, and he's so overwhelmed with all the military and Joe Rogan and all that stuff. But there's a lot of other doctors I could bring up, but those three guys still have a practice that is thriving, and they take new patients, and they would love to work with men that listen to your show.
Well, I'd
By the way,
love for them to do that.
I don't make a cent recommending them, just so guys know. They don't pay
No,
me.
no, I understand. I understand. That's good of you to say that, but we don't want to give anyone the impression that we're fishing for commissions here, because we're certainly not doing
Yeah,
that.
no,
But
of course.
we've
And by the
got
way,
you know, we got a whole bunch of people. People ask me this all the time. People ask us every seminar. We see guys that are in the seminar that are not on testosterone, that need to be on testosterone. They're asking me, well, what do I do?
yeah,
And the only option I've got for them right now is to go to a TRT clinic. Most bigger markets have got at least one.
yeah,
And that's the closest you're going to be able to do
yeah,
that to a situation that makes any sense. Because if you approach your general practitioner about this, you're going to be dealing with somebody that doesn't know anything more about this than the girl at the cleaners.
yeah.
You know,
Or their receptionist.
or I mean, you know, the
Literally.
they don't have the slightest idea what
Clueless.
they're doing, and it's harmful to ask them about it.
Yeah. No, you're 100% right.
You need to go to somebody. So in the absence of access to a guy that's got his head out of his ass, a TRT clinic is the most accessible option. But these four guys that you've mentioned today, put that we have this show carries a transcript with it, and that'll be available. And their names will be available, the contact information in the transcript. So you guys that are wanting to know what that was, just look down in the transcript, and it'll be there. What would you say an optimum therapy program would look like for a guy that's into this that's still trying to find his level versus a guy that's been doing this for 5 years?
Yeah, it's a good question. Let me go back to address something though you said too about the TRT clinics. I call them windmill clinics. It's very important, especially and you're right. You said there's every major city has one. I mean, if you're in a major city, you got hundreds to pick from. They're all over Google. It's very important, and you said this very early in the show, Mark. It's very important that men do this right from initiation, because if you go to a TRT clinic and they put you on 10 different things, there's absolutely no idea to know what the testosterone is doing molecularly in your body, because it's not in isolation.
If you start a therapy program and there are 5 variables in it, it is impossible to say which one of those treatments are responsible for what happens to you. You can't tease the effects apart.
Exactly.
So if they're doing cream, sublingual injections, and AI, if you got all of that shit going on at the same time, you have no idea what happens.
It's insane.
Yeah.
It's literally insane. Plus pregnenolone, which as you know is a steroid precursor, a mother hormone, and then they're giving them melatonin, they're giving them HCG. You got like 7 chemicals.
What they're doing is they're trying to run up the bill.
Make money.
You want to go to a clinic that gives you an injection of testosterone propionate, and that's all.
That's it.
And that's
literally.
all.
That's it.
And then
see how you feel.
They can vary the dose, but if they're putting more than one thing in you, go to another clinic.
Exactly. Yeah.
So
it's beautiful, man.
So that's how you start. What does it look like 5 years down the road?
It's another good question. I mean, you really, once you get balanced and leveled out, you don't really have to increase the dosage. I mean, depending on what your lifestyle is and what your goals are. I mean, if you're a strong man or a professional athlete or a power lifter or something, maybe you want to bump the dosage a little bit. Maybe you want to use peptides or consider a human growth hormone or something. Again, it's all relevant to your goals, but you never have to tweak your dosage. I mean, I've been on testosterone therapeutically now for close to 20 years. And my dosage never changes. I mean, 18 years of injections and now 2 years of the cream on my balls. And, it's the same thing. I wake up in the morning. I take, after I get out of the shower, I just take a couple clicks of the dispenser right at the base of my balls, wash off my hands, good to go, right? If a guy's injecting, again, I recommend that you do at least 3 times a week. And if you're needle phobic or you hate injecting yourself, at least twice. And let's just talk about that for 1 second. You want frequency because, again, the way the ester cleaves in the system,
it levels out the blood,
so
the serum levels.
You want to hit the nadir as it's coming down. You're hitting it going back up again, so you're always kind of like this.
Right.
Yeah.
Right, but at a TRT clinic, you're going to get one a week.
Yeah, for the most part.
And that's better than nothing.
Than none at all.
That's better than none at all. Especially if it is an injection of 200 milligram of testosterone. And if that's what's available to you, then that's what you do.
Exactly. Yeah, testosterone injected once a week is better than none at all. Let's make that very, very clear.
Oh, yes. I think it's important because that may be, for most people, the only option they've got.
Well,
and if your option is 200 milligram a week of testosterone IM versus a transdermal patch, there's no question. There's no question.
Go buy some pills or some andro boosters or whatever.
Yeah, it's about the same thing. So it's not
exactly.
There's no question as to which one you do. Optimum would be more frequent, but if all you've got access to is 1 shot a week, then that's what you do. Now, it's also going to be important to understand that this is not necessarily cheap. It's very seldom cheap. How many insurance plans will cover testosterone replacement therapy?
Good question. Now, with everything that's changed and the way they're coming down on the
probably none.
The state medical licensing board, none.
I think this is probably all out of pocket. I think it's going to be all out of pocket. And
no
really,
legitimate doctor.
And really, Jay, that's the way you want it. I don't think you want to be on record as being on testosterone.
Exactly.
I think it's probably to your advantage that all happens out of pocket, and that remains
100%.
the business of you and the guy that's doing it for you, and that's all.
That's right. That's right. And by the way, that's a good point, because if you're, from a life insurance actuary table,
because they don't understand it, and I don't want them figuring it in as a variable and doing the math wrong, because that's what they'll do. It's exactly what they'll do.
You're a prostate cancer or heart attack cancer candidate now. Yeah, right. You can never. You're right. Good point.
No, you can't tell them what you're doing on that. They just don't understand the data.
No clue. They're years away from understanding that.
Right. If they ever do.
Yeah.
Well, anything else you want to cover today, Jay? This has been real good. We need to get back in touch about the PSA thing. I want to talk about that. That's worth an entire show. If you'll get prepped up. Did we leave anything out today you want to talk about?
Not really, man. I mean, it was phenomenal. You asked really good questions.
Let me go ahead and plug the book again.
Sure.
Here it is, the Testosterone Optimization Therapy Bible. It's about 600 pages, very dense information. Get it, read it, make up your own mind, do some research on your own. And but you guys that are in the situation where you need this stuff, I think you know who you are. And if you don't know who you are, you need to think about it. It's not good for you 55-year-old guys, and I keep saying 55. It might happen at 38.
Yeah.
You might be fine till you're 70.
Yep.
It varies with the individual. All of this stuff varies with the individual. But if you're sitting around not feeling like you know you need to feel, why don't you consider this as a primary treatment for that? Because it doesn't hurt anything to try it. And B, it doesn't take very long before you know exactly whether it's going to work or not. These two things are very, very important. If your doctor goes in and gives you a loading dose of 400 milligram of testosterone, the worst thing that you could have happen to you would be you wake up every morning with steel. And that's not a bad thing. I think you'll agree that's not a bad thing. But if in 72 hours your outlook on life has radically changed, then I think you'll find that you're happy with this as an option. Jay, thanks for being with us today.
Mark, man, it's humbly privileged and an honor. And let me just say again real quick, for the guys who are too lazy to buy the book, I give this out. It's just important for me.
Give us that web address again, and we'll...
Yeah, for sure. jccampbell.com/free books. And not
That's
only
JAYC-Campbell.com.
Exactly. Yeah. Right. And not only will you get the free book on the Bible, the PDF, you get it downloaded immensely. It's got all, the links from like the people like you that have interviewed me that will go back and, deep level detail. And obviously I'm going to put your podcast when it comes out too there.
Right.
It's a very important topic, as you know.
It is a very important topic to those of us in this business and those of us that are in the business of being males at the age of 64. I think you'll find that this is an important thing that you can do. I want you to seriously consider it. Jay, thank you for being with us today.
Thank you, Mark.
And thank you guys for being here on Starting Strength Radio. We'll see you next Friday.